Okay, all. Welcome to another edition of 10 Minutes with JPIDS. I'm your editor-in-chief, Ravi Jhaveri, and I'm really excited to discuss a new paper. Today we have Annie Wirtz and Stephanie Duehlmeyer. Did I get that right?
You did.
Excellent. Great. They're at Children's Mercy in Kansas City, and they are part of a team that published a paper with us that's still in our advanced access, describing changes in antibiotic use with the new CFTR modulator therapy. So, welcome to both of you.
Thanks for having us.
Absolutely. Our loyal listeners, however many there are, know that the first question from me is always the same to our guests, which is that I'm a superhero nerd, and every superhero has their origin story. So I'd love to hear from both of you. How did you guys get involved with being infectious disease pharmacists? How did it start? So,
Back in my pharmacy residency, I had a great idea that I was going to go into critical care. And I staffed some shifts in between my PGY1, PGY2 pharmacy residency, and that did not go well. And so going into my PGY2 at Children's Colorado, I was really looking for kind of another focus area. I always really liked ID. So that was really kind of my first rotations, and I became more in love with ID and antibiotic stewardship in general through their great team over there. And, they always say things work out how they're supposed to. And a job opened up back here in my hometown, Kansas City, and was able to end up here. I worked in IDASP for about 8 years and then just took a 1 year hiatus working in med safety. And actually, today is my first day back in antibiotic stewardship as the program director. So
awesome. Welcome back.
thank you.
Yeah, my name's Stephanie, and I am actually not an infectious disease pharmacist. I'm the pharmacist at our cystic fibrosis center.
Oh,
Um,
okay.
yeah, so just a little bit of history for me. I did pharmacy residency here at Children's Mercy, and my mentor was a pharmacist in the cystic fibrosis center. And so after I finished my residency, she had applied for a grant through the CF foundation to get a second pharmacist, and that's how I ended up in my role. So I've
Awesome.
been in this role for about 8 years. And then, yeah, background for like the paper and the podcast, we follow about 250 people with cystic fibrosis every year here. We follow kids from Missouri and Kansas, and we've got a few that are like in Oklahoma and Arkansas as well. And I've been in this role for about, I think I said that already, 8 years. And I follow kids on the inpatient side as well as in clinic. So
Awesome.
see them kind of wherever they show up here at the hospital.
Yeah, thank you so much for sharing. And thank you also for that additional perspective, sort of on the geographic footprint of the Children's Mercy program. So let's dive in. One or both of you, how did you guys decide to start this project?
Yeah, I'll take the first stab at this, but it really kind of started with a new medication called Trikafta or Lexicaftor, Tezcaftor, Ivacaftor. It's a triple combination medication that is in the class of medications called CFTR modulators. So when it was approved back in October of 2019, it really was a game changer for people with cystic
Hmm.
fibrosis in the whole community. So not only was it more effective than anything we'd had before, but it also meant that 90% of people with CF could benefit from this therapy as well. So just a more widespread use and exposure to CFTR modulators. So as Trikafta became widely used, we started noticing an interesting pattern. So patients weren't really needing antibiotics as often.
Hmm.
Both oral and IV courses were going down. We also noted like way less culture positivity for Pseudomonas aeruginosa. So that really got us thinking, like, if these trends are real, what does that mean for how we're going to treat pulmonary exacerbations in people
Yeah.
with cystic fibrosis? So yeah, after some conversations with our ID team, we kind of set out to test the hypothesis that overall antibiotic prescribing has decreased after Trikafta, especially again for those like big broad spectrum drugs that we use for multi-drug resistant organisms.
And I think Steph and I were kind of talking this morning about how did we come up with doing this particular project. And at the time, back in antibiotic stewardship, we were trying to do a journal club series where we would
Hmm.
have people come from other areas to present. Like we had GI come and talk about like antibiotics for small bacterial overgrowth, just so we could learn a little bit more in the areas that oftentimes we felt like we had lower compliance with our recs. I think CF is a really hard area to steward
Yeah.
in. And so we invited our friends to come tell us about their data and help us understand their program. We have a really well-developed program here. And so we're always trying to look to learn from the stewardship side of things. And in seeing their data and like their decrease in number of patients, we really were kind of wondering the same question of, had they looked at this data, could we look at it from a national level and then go
Hmm.
on to publish it? And how does this kind of change the world of stewardship in CF?
Yeah. No, I love it. And this is, I think it's cool. So one, I love that story. And two, I think it's cool because it really does go back to sort of the physiology and pathophysiology of CF, right? And the idea that if you fix the underlying problem, the hope is that all the downstream stuff we see will eventually get better. And so it's a tight story and it's great that things that work. So, sort of following on then, were you surprised by what you saw?
I
Or was it pretty much in line with what you expected?
I would say overall, I think, our hypothesis was that we were going to see a decrease overall in antibiotic use. And that's really what the paper tells that story. I think based on, our own institutional experiences, I mean, we had seen our CF team go from being a primary team to having fewer patients on the inpatient time side to just being a consult team. So
Hmm.
we were really expecting to see that on the inpatient side. And then given like the widespread use of CFTR modulators and their positive impact, we thought we would see it across the country. I would say that there's kind of one area that I think is surprising in some sense, but maybe not necessarily, is that the duration of treatment really didn't change. So in our single center portion of the study, the duration is basically the exact same pre and post
Hmm.
immunomodulator introduction. And then in the FIS portion, we looked at median length of stay as a marker of duration, and this changed really from 11 to 9 days, which is a decrease, but I would say really isn't clinically significant. So this kind of is an area that I think we'll talk maybe more about in a little bit of what we feel like maybe we should be looking into more.
Stephanie, anything to add there?
No, I think she covered it.
Okay. Um, and so many of us who have worked with Fizz know that like the Fizz data is very high level, right? It's kind of the summary. So, but what other clinical details do you feel like we still need to focus on in the future, or what you couldn't get in this study?
Yeah, and we will preface this by saying we're not phys experts. We
Sure.
work with the wonderful Brian Lee and Josh Harrigan on this paper, and they, are way smarter than us when it comes to phys. But kind of some things that we felt like, we missed out on by doing phys, or what we couldn't get from phys, is one, I think outpatient antibiotics, which you tried to make up for with our single center portion of the study.
Hmm.
As we know in ESP, majority of antibiotics are prescribed in the outpatient setting. And so while we wondered, were less patients being admitted with CF and we're getting less inpatient antibiotics, it still could be very likely that they were receiving outpatient courses, especially because COVID-19 was in the middle of our study period. So with our own internal data, we were able to show that we saw a decrease in oral antibiotic courses at our own institution. But I think kind of nationally, that's something that I think that we could further look into. We also couldn't get culture data in
Yeah.
particular from FIS, but there's a variety of papers that we cite in our study that show a decrease in resistant pathogens.
Yeah.
I think one of the big questions is, how do you put together the cultures and the use of antibiotics and need for broad spectrum use? And that's really, I think, a future area of research.
Love it. And I can just attest, I've collaborated with Brian Lee before, and he is one of my
He
my
is
go-to Fizz guys. So
God.
I'm
He
I'm
is
I'm
just
with you on that.
good.
This is a little off script, but it makes me wonder too. You talked about the fact that the Trikafta drug now will cover 90%, but it seems to me that we're going to end up focusing a lot on that 10% that is left out, right? And they're
Sure.
gonna they're gonna overrepresent the kids who need more antibiotics, who are in the hospital more frequently, who really aren't yet able to take advantage of this class of
Absolutely.
drugs.
Yes. I mean, here in Kansas City, we average probably like 1 to 2 people with CF in the hospital at any given point. And usually those are the ones that don't qualify for CFTR modulators based off of genotype.
Hmm.
Or if they're in the hospital, maybe they're not as adherent to their CFTR modulator as they
Yeah.
should be. So that I feel like kind of encompasses like our two main groups of people that end up in the hospital. But yeah, you make a great point that
Yeah.
yeah, the people that don't qualify, they're still going to have pulmonary exacerbations and need to be treated like old CF, like we say.
Yeah. And I say that just because I'm kind of the person in our group that's the uh the doc that most often collaborates with our pulmonologists about the CF kids with CF, and so I'm seeing the same thing you're seeing, and so we've discussed this a lot, and I also feel like that group, unfortunately, is the ones that are disproportionately still suffering
For sure.
with these issues.
Yeah.
So just thinking about going forward, how do you think people should use this data, either for their clinical care or perhaps for to inform their future research?
So I think that overall, like, what does this mean for prescribing antibiotics? Obviously, that's kind of like the big question. So we saw a huge drop in oral and IV antibiotic use after Trikafta. So how can we think about more conservative strategies for pulmonary exacerbations, especially these patients on these highly effective modulators? Do we always need to start antibiotics, or is just, increased airway clearance enough?
Hmm.
And then I think kind of the other part of that is thinking about with seeing fewer MRSA or pseudomonal infections or other resistant pathogens, do we always have to reach for these broad spectrum drugs? Kind of like what you were saying, we've treated the underlying problem. So can we just be reaching towards your standard ampicillin or amoxicillin for
Hmm.
rather than these broad spectrum agents every single time? So overall, in my mind, I see this as kind of a great opportunity for stewardship to really shift in the setting of CF. I
Yeah.
think there's those still kind of like you guys were mentioning, those one-off patients who maybe don't qualify, where I think we collaborate a lot of like, what are some unique regimens that we could start them on when they're admitted with these crazy resistant pathogens. But then on the flip side of things, how do we like lend our minds and work together to make sure that we're treating effectively without overusing antibiotics?
Yeah.
Yeah. And then as far as the future research, some of the things that I just wanted to comment on, and I think the big gaps that the CF Foundation is really focusing on is what is the right duration for a pulmonary exacerbation treatment. There's no
Hmm.
standard number of days. So I think that that's a big
Yeah.
thing that they're continuing to research. And I think the other area is also like, do we really need to double cover Pseudomonas aeruginosa in a patient that is on highly effective CFTR modulators? So the CF Foundation is doing what they're calling the STOP clinical trial series. So that
Yeah.
stands for their standardized treatment of pulmonary exacerbations. So I believe only one of the clinical trials is actually completed, and that was the STOP 2 trial that was in adults and looking at duration of treatment, and really kind of showed that like longer durations didn't necessarily mean that they got better or had a better recovery and lung function.
Yeah.
I think that was interesting, but they've also have the STOP 360 trial that's ongoing, and that's looking at the double coverage of Pseudomonas, like do you need that aminoglycoside or not? And then STOP PEDS is also currently enrolling, and that's looking at, like Annie mentioned, they're randomizing people to airway clearance first or
Hmm.
antibiotics first. And again, seeing if
Yeah.
our younger population can kind of kick these infections with just better airway clearance early
Yeah.
on.
I think that sounds great. I have one topic maybe to also suggest that maybe you guys can agitate for people to consider, which is that I've had this experience, and maybe you have had too, is that I think we probably need to also change our dosing recommendations for kids on the modulators, because I've had kids that have had toxicity when we use the classic CF dosing because their volume of distribution now is totally different.
For sure.
And maybe you guys are already doing this, but I don't know if there's efforts to really bring attention, because I'm also worried then about the adverse events in this population.
Yeah, I think that's a great point. And I think there is some very small single center data on like tobramycin, for example, and needing lower doses for people that are on CFTR modulators and kind of looking at that. But from like an antibiotic perspective as a whole, I'm not familiar with any data right now in the CF population, but I would agree with you, and just like anecdotally in my clinical experience, the people that are on highly effective modulators, especially those that have been on them for a while, seem to
Yeah.
have what we would consider a normal pediatric pharmacokinetic profile.
Yeah.
So yeah, definitely need to be mindful of that for sure.
All right, sounds good. Anything else you guys want to add that we didn't cover?
I don't think
I think it was
so.
everything.
Excited about the paper.
Yeah, we appreciate
Yes.
the invite.
A long time
Well,
coming.
Yes.
Yeah.
absolutely. Well, thanks so much for joining us. Thanks for doing the work, and we look forward to the next project you guys are gonna put out in this space. But good luck with the future work. Thanks so much for joining us, and I'll just close out by saying thanks all for listening, and we'll see you on the next episode of 10 Minutes with JPIDS.